Now it gives me great if I could just introduce Nick McInnes. Nick is passionate about improving the way we deliver healthcare. He's been shaking things up in Italy, Belgium, and now here in Australia. Nick is currently the project lead for the Patient Flow Partnership at Peninsula Health and brings to the role experience from redesign work at public and private hospitals and the pharmaceutical industry. He holds an MBA and an MPH. He'll be talking today about improving emergency access in winter. Please welcome Nick McInnes.
Thanks for that. So, hi everyone, my name is Nick and I'm the project lead for the Patient Flow Partnership. I was also the project lead for the Improving Emergency Access Collaborative last year at Peninsula Health. And I'll be telling you about what we have called our Care Huddle system, which is our version of our DOS, Daily Operating System, also known as a Daily Management System. Before I do that, I have two disclaimers. First of all, we didn't introduce this as part of a winter plan. So this wasn't specifically introduced to address winter demands. It was a coincidence that we launched it in the middle of winter. I think it was unfortunate that we did that. We probably should have done it earlier. So I don't think we really experienced all the benefits that we could have had if we'd done it a bit earlier. But I think this year, fingers crossed, touch wood, we will have at least a system in place that should help us somewhat. And the second disclaimer is that we didn't invent this stuff, so we can't take credit for it at all. We learned about these huddles as part of the collaborative. We went and did a lot of site visits. So we saw, Eastern Health, St. Vincent's, the Northern Health, all have versions of daily operating systems in place. So we learned a lot from that. And this is simply our version of it. So we took a bit of everything, added a bit of our secret ingredients, and this is what we've come up with. So we've called it our Care Huddles. I'll talk about why huddle, what is a huddle, how does it work. I'll describe the system that we designed, and I'll give you a few examples of some of the wins that we've achieved so far. And I've just got one slide on the evaluation so far to see, is it actually working for us. So why huddle? That's a photo we took in the middle of winter last year. If you count them, there are 10 ambulances ramped outside of our emergency departments. And those are obviously 10 ambulances that are not out in the community serving our patients where they really should be instead of waiting to be off-ramped. And that little we don't have a laser pointer. Anyways, that little picture in the bottom right-hand corner is what it looks like inside when you've got patients ramped on gurneys. It's not an ideal situation. So we really felt last year that we were struggling to meet demand. It felt exceptional, I think. I'd only been in the health service for 6 months at the time, but everyone I was talking to said this is really unprecedented. So we felt like there was something exceptional happening. The demand was far greater than anything that we had experienced in a long time. At the same time, to make things a little worse, I think a lot of people were frustrated. They were working very hard, and they felt that that wasn't really translating into improved flow. I think people felt they were being let down by our management system. And somebody said, it's like Groundhog Day. We're trying to fix the same problems over and over again. We're having the same conversations with people. We heard earlier, winter happens every year, and yet every time we're caught a little bit short. So we looked a little bit deeper at what parts of our management system didn't work for us, and these are some of the elements. So difficult communication. We didn't have a regular opportunity to catch up face-to-face with line managers, direct reports, or your peers. Unless you're lucky to have a standing meeting in someone's calendar, you had to resort to emails, phone calls, and getting responses and progressing projects took a long time. Especially if you have a visiting workforce, it's difficult to make sure everyone's on the same page at the same time. So you do end up repeating a lot of the messages and the vision over and over again. So communication was a problem. We had unproductive bed meetings, ineffective and I'd say inefficient bed meetings. First of all, we had them 3 days a week, Mondays, Wednesdays, Fridays, which is already kind of an odd pattern. So you take people off the floor at a time of the year where you really want them to be on the floor for half an hour at a time, and they would wait for their turn to have 15 seconds of fame where they'd give their little bit of information around planned discharges and expected beds to become available. But by the time we had those meetings, that information was already out of date. And by the way, we had already introduced a project called Countdown to Discharge, which meant that we already had live information around who's going to be going home in the next few days. So the whole thing, the exercise itself, had become obsolete. So so that was not very efficient. We were not very good at problem solving. It took a long time to get things fixed. So you typically log a job with IT and roll your eyes, and people go, oh, it's going to take forever. Same thing with facilities. And I think people had just generally lost confidence in our ability to solve some of those big issues. It's like a message in a bottle, a black box. You log a job, and then you sort of never hear back from it. So people start developing workarounds, and then workarounds on workarounds, never really getting to root cause, and it's extremely wasteful and doesn't really solve problems. And finally, we didn't really have an overarching improvement framework. So there were pockets of improvement and innovation across the health service, some great ideas being invented to try and solve problems, but that was not being shared systematically. We didn't have the same approach, weren't using the same method, and we certainly didn't have a central repository to sort of celebrate and share all these things that were happening in the health service. So I think the combination of this and a few other factors really meant that not only did we have a lot of demand, but we were really struggling to catch up internally. At about this time in the collaborative, we started to notice that some health services were doing quite well. So this is, I keep calling it the horse race, but it's a scale from 0, which is intent to participate, all the way up to 5, which is outstanding, sustained results, I think. And it's a measure of how the projects that we were coming up with in the collaborative were progressing. We had initially sort of left the gates really early, but we found that other health services consistently progressed and then overtook us and ended up leading the pack. So we were really interested to know, what are they doing differently? What sort of systems do they have in place to help them make sure these projects get implemented correctly and lead to the expected outcomes? So we really started to focus on, as I mentioned earlier, Eastern Health, Northern Health, St. Vincent's and others, to see what have they got in common. And it turns out what they had in common was some form of a daily tiered huddle system or a daily operating system. So we got really interested in that concept. And the first thing we asked was, what's a huddle? What goes into a huddle? And it turns out huddles are very simple things. They're a very natural thing that people do when they're under pressure. They kind of stop what they're doing, they get together, they huddle, and they say, how are we doing? What's working? What's not working? What do we need to work on? What do we need to focus on to be able to respond to what's happening to us and win at the end of the day, if this is a sport. So huddles happen in many industries in different shapes and forms. Sports is a great example. At halftime, what do people do? They don't just walk off and do their own thing. They get together and figure out, well, how are we doing? What do we need to focus on? What's the plan? And the important thing is it happens during the game, not a week, a month, a quarter later when they get feedback or data on the game, right? So we get that a lot in healthcare. Feedback comes a bit later. And if you solely rely on that, you're not going to be able to respond to things as they emerge. So having a timely, high cadence of management is going to be a key component of whatever management system you come up with. So that's what it looks like conceptually. Now, in practice, how do you take these concepts and apply them into a health service? Well, this is a conceptual representation. You can have a number of huddles during the day. So it starts off with generally a tier 1 huddle, which happens on the shop floor, typically first thing in the morning, with ward staff and either an ops manager or ops director who goes and has a quick, structured 10-minute conversation with them about how did we do yesterday, any safety issues to plan for the day, go over some metrics around flow, anything or questions around resources and equipment that could be barriers to flow that need to be resolved. Anything that can't be solved locally then typically gets escalated to another tier. That's why we call it a tiered huddle, because there are multiple huddles throughout the day, throughout the morning, I should say. Typically, you might have an intermediate level huddle where the ops directors or whoever went out to the first level huddle get together, share anything that is left over that couldn't be solved locally. They ask, what can we do to try and help at our level? And then you would typically have the highest level is exec, and within a couple of hours of an issue being raised on the shop floor, they know about it. If there's anything that they can do, they would try and solve that as well. So that's, in a snapshot, what a tiered huddle system could look like. Frequently, there's also a part of it that's not a daily huddle, but it's a weekly or fortnightly look back at our performance. So this is a picture from St. Vincent's. They have this fantastic wall set up where they've got different domains, so safety, quality, access, staff cost with different indicators, and every week people gather around it. It's like a ritual. And look at how we did last week. Is there a gap? And Nat was talking about the gap between expected performance and actual, and what are we doing to try and close that gap if we can? So I think those are really important parts of what a tiered health system looks like. This is a photo we took at Eastern Health. This is a GenMed Ward, I think. This is Patrick showing us what the sheet looks like. It's a very simple piece of paper with different columns for each day of the week, different rows representing standard questions to ask, typically starting with things around safety and quality, questions around flow, resources, etc. And it's just a way of, in a structured way, gathering a snapshot of how we're doing right now and if there are any barriers to flow. This is a larger version of the picture I was describing earlier at St. Vincent's of the wall. I think it's changed a lot since we went there. It's, again, a high pace of change, which is a great thing. And so the system really works. It works for a number of reasons. First of all, it provides a standard process to try and gauge our daily readiness. So answering that question Nat was talking about earlier, are we ready today to meet our demand? If not, why not, and what can we do? It helps identify problems early. It enables people to escalate, but it doesn't substitute local problem solving. In fact, I think it fosters it because it gives people the reassurance that if they need to, they can escalate and things will be solved. But the first question they'll be asked is, have you tried locally to fix this first? Show me what problem solving you've done. And so it provides both the safety net that there's a way of escalating, but also promotes the development of problem solving skills locally. It creates transparency around current state, accountability for the issues that we try and solve, and the certainty of a daily opportunity for face-to-face communication. Some of our NUMs used to say that you knew you were in trouble when you saw your ops director. That's how infrequently they saw their ops directors. That's not a criticism, it's just that everyone was really busy and we didn't have that system in place. Now they have a daily structured conversation with them. So obviously that improves the rapport and the flow of communication, and issues, I think, are much more likely to be raised that way. And ultimately, I think it really will improve patient care on a daily basis. So we decided to design our own system. Those are just a few photos from the workshop that we put together to try and design this. We had a big cross-section of the organization get together to try and understand, well, what can we take from all the different health services that we've seen, and how can we tailor it to our health service? And we came up with this structure. So for us, we've got essentially 2 daily tiers. So the tier 1 is what I described, with the ops directors going straight to the ward. And then we have straight to tier 2, which is the highest daily level that we have. And that's the big one. That's the big meeting with chief exec, all the execs, all the ops directors. A lot of the clinical directors turn up regularly as well. We were surprised. We were hoping that that would happen, but we were not expecting 5, 6, 7 clinical directors every day to come to this. But then there's a whole host of other people as well. So IT are there, facilities management, pharmacy, pathology, radiology, redesigning care are there. Everybody comes to this to know, how can we help? What are the things that we can work on today to help make sure that we're ready to meet our demand? And it lasts exactly 15 minutes. A meeting that big has the potential to be very expensive. So we were very strict. It starts on time. It ends almost exactly at 10:00 every day, depending on who's running it. I think we're pretty happy with the way that Tier 2's turned out. We're working on a Tier 3, which would be the equivalent of what we saw at St. Vincent's with that weekly look back, but not fully there yet. And we recently introduced a Tier 0 huddle, which happens the day before. So it's a 3, 4 o'clock huddle on the wards to try and look at, is everything in place for our patients going home tomorrow? If not, can we make sure that it's ready so that we can get early discharges the next day? And that's an idea we stole from the Northern. So that's what it looks like in practice for us. This is just an overview of the Tier 1 sheet. So it starts off with safety and quality. We always ask about any incidents since the last huddle. There are a number of questions around flow. Did we get the expected number of discharges that we wanted today? If not, why not? What happened? Are there any barriers? Things around staffing and resources, equipment, and so forth. So this is what it looks like in practice. It's a small, quick huddle, usually involves just the NUM and the ops director and anyone else who can come and contribute. That's on the wards. That's in ED. ED is where this really started. ED is sort of our lab. We've got a very engaged workforce there. So you'll notice there's a whole orange section at the bottom of that, and that was because after about a week of huddling, they thought, this works. We should have another in the day. in the afternoon to prepare for night as well. So that's what it looks like in ED, that's in mental health, that's in theatre. So the different ways of running huddles, but the important thing is that we've now got them happening all across the health service in subacute as well. So that makes sure that every day within the first hour, so 8 to 9 o'clock, we've got intelligence on how things are going across the health service. We've escalated the issues that need to be escalated, and they go to tier 2. So this is the sheet that we follow for tier 2. Again, starting with safety and quality, any incidents overnight, any safety issues to plan for the day. Then we recently started looking at roster or absences yesterday, which is we learned from last winter, something we need to monitor very closely. We look at who's currently in ED, who's admitted under what units. So the ops directors for each, for medicine, for surgery, report out how many of their patients are currently in ED and whether or not they have a time, if they're ready to go. Then we look at demand, so forecast demand and planned capacity for the day for each of the areas, and that allows the ops directors to give us a red, amber, green status. So do we feel green today based on our expected match up between supply and demand, amber or red? And if you're red, the expectation is that you'd stay back after the huddle and hash it out with ops directors to try and figure out what we can do to help. And then there's a section there to try and allow the opportunity to raise issues that couldn't be solved locally. And then we go to the board with all the issues for follow-up. And I've got a picture of that in a sec, I think. So this is what tier 2 looks like. This was actually an old photo. Now it's become even more crowded. More people want to come to this because it really is where you hear about how things are going and you have an opportunity to influence flow for the day. So that's the first 15 minutes. It's a very structured Q&A format. But the beauty of it, I think, is the next 15 minutes. So formally, the meeting has ended, but what tends to happen is that people naturally congregate and catch up with the people that they've been meaning to talk to, but they haven't had a chance. Now there's a daily opportunity for that to happen. So this is problem solving in action. You've got all the ops directors and IT and pharmacy. If they need to catch up, they don't need to send an email. They don't need to set up a meeting in 2 weeks' time because they know that tomorrow morning I'll have a chance to catch you after tier 2. So I think this is one of the powerful elements of our tier 2, and we've been sort of fostering or promoting the informed part of it as well. I mentioned the issues board, so anything that gets escalated that needs to be followed up gets tracked on a card. It's nothing high-tech, it's not very sophisticated, but it works. It's a little Kanban system. Each card has who raised this, who owns it, what's the problem, what's the expected action, what's the due date, and based on the due date, we move them according to the columns. The leftmost one is due in less than 2 days, and less than 7 days, 21 days, and so forth. So it really brings us transparency over the issues and accountability as well. So it's not a good look if it's due and there's all of your peers, all the executive directors, the chief executives in the room, and you haven't done the thing that you said you were going to do. So it does drive a bit of accountability there. And to the right, you'll notice the little Velcro dots are the red, amber, green status that gives us at a glance every day a sense of where the pressure points are in the health service. So that's what our tier 2 looks like. Now, just a few examples of some of the things that we've been able to solve. We had a problem for 3 years. Apparently in ED, every single overhead announcement, so thank you morning staff and stuff like that, got relayed to one of our surgical wards, day and night. And for 3 years, I think the common wisdom was, well, it's a user issue. It's a user issue. So you'll note, I only discovered this after I took the photo. There's a piece of tape there on one of the buttons that says, do not press. And there's a big arrow and another thing over there. But I think the response was, well, more education, be more careful. And this was raised at tier 2 in the first week of us having that. And within a week, we had engineering on site. They called out contractors who identified faulty wiring, and we solved the issue. So that was pretty powerful. It sort of demonstrated to people that we had the power now to actually solve these historic issues. This is another one. We had, ahead of a long weekend, Rosebud is a hospital on the tip of the Peninsula. We were expecting a weekend of high demand, and we got this sort of SOS a few days ahead of the weekend saying, we're running out of pumps. All of our pumps are disappearing. I think they're going off with patients to Frankston Hospital, but they're not coming back. Can you help? And I think they tried to do some finding and were unsuccessful. When this was raised at tier 2, within about 24 hours, a sort of a team was deployed to go and find the stuff, and they found 30 pumps and 12 extra syringe drivers that had Rosebud Hospital written on them, hidden in different cabinets and sort of storage things. So they were then sort of express couriered back down to Rosebud Hospital. So again, making sure that we were ready to meet the demand that we knew was coming for the weekend. And this is just another small example, but we recently introduced a whole set of new cordless phones. I think staff had locally been complaining about the battery life of these new devices. But it wasn't until it was escalated to Tier 2 as a coordinated voice that we were able, again, in a very short time frame, to realize there was some, what did I say? Yeah, a network setting change needed to be made, and that fixed the battery life issue overnight, practically. So it's a powerful escalation mechanism, and people, I think, are starting to gain more confidence in the systems that we have in place to solve problems. So just one slide on how we're doing so far. This isn't up to date. We sent out a survey a month after we started, so it's still very, very early days, but just to get a sense of, do we think this is adding value? Is this working for us? And here are some of the responses. So it's not, on the right, it's not 1 to 5, it's 0 to 5. I want to point out, so there's no middle value, so it's not a coincidence that it's all 3s. But I think the most value that people are seeing are in the timeliness and the appropriateness of escalations and the ability to get feedback on those actions. The improved patient flow is kind of in the middle there. I don't think people have yet really realized the benefits to patient flow directly, but I think by having the system in place, we're going to start making start fixing a lot of small problems that would otherwise have lingered that should ultimately improve patient flow. So I think if we redo this survey now, fingers crossed, we'll see an improvement on most of those metrics. And the key qualitative bits of feedback around Tier 1 is that it really helps getting things escalated and solved early, and recognition of staff. What else have I got? Gives us a good snapshot of how we're doing. And Tier 2 as well, you've got all the right people in the room. You can immediately start problem solving and creates transparency and accountability. So that was just a quick snapshot of our experience with DOS. Again, I don't think it's specifically aimed at improving flow in winter, but I think it certainly can help, and I hope you'll give it a go, perhaps. Thanks.